Can't rename myself though. All right, that's fine. All right, tell me guys, are you seeing the screen for non-diabetic emergencies?
Yes, sir.
Yes, sir.
All right, we're gonna go to 2.
Yep.
Can you see the objectives there?
Yes.
Yes.
Yep.
All right, very good. All right, let's get started. Okay, welcome to this roundtable. This will be a short one because this is not a heavily tested subject on the NREMT. As you know, I write questions for them and I sit on their committee that approves the tests and such. And this year in the cycle 5 and cycle 6, which will be coming up, endocrine emergencies are confined to diabetes, and you'll get the occasional thyroid issue. But it's going to be so clear from the scenario that you can't miss it, because they're going to mention that the patient is either on thyroid medication, such as Synthroid, and subsequently, your patient is either going to have an overdose, which is too much Synthroid, which will too much thyroid hormone, and it spins a person up, and you'll get one set of symptoms. If they take thyroxine, Synthroid, and they don't take any of it for 1, 2, or 3 weeks, or they say, well, I'm hypothyroid, but I ran out, you're going to get another set of symptoms. As far as the others, the Myxedema Coma that you see, adrenal insufficiency and myasthenia gravis, they're included to complete the non-diabetic emergency section, but you'll be lucky to see one question on thyroid or Myxedema Coma. We don't have anything on adrenal crises. And myasthenia gravis is so rare that when we teach emergency medicine doctors about myasthenia gravis, we warn them that they can be in practice for 20 years and they may see one patient with MG. What happens is with myasthenia gravis is that they start losing their ability to effectuate nerve impulses to the diaphragm. Subsequently, because of the lack of the chemical choline, cholinesterase and such that sit at the synapse between the nerve and the muscle. In other words, the synapse is the junction or the space or the link up, whatever you want to call it. But a chemical has to shoot across the synapse to allow the nerve impulse to go. It's kind of like a drawbridge, if anything. And when they run out of that enzyme, that cholinesterase, then they can't get an impulse to the diaphragm. As a result, they start having difficulty breathing, but not in a traditional sense of asthma, emphysema, congestive heart failure. They have difficulty breathing because they can't move their diaphragm. And so that's the only thing that you're going to need to know about myasthenia gravis. I give them Tensilon in the emergency room or whatever the favorite drug is right now, and they're fine. But we don't teach it. Don't worry about it. It's included here just because this is NREMT slides. But the thyroid storm is when they have too much thyroid, and Myxedema Coma is when they don't have enough thyroid medication. So what do you do for these patients? And we're going to get into that right now. So this is the classic hypothalamus to the thyroid stimulating hormone to the thyroid. Look at that straight down, those arrows. The hypothalamus, which is in the brain, regulates temperature, but it also secretes 9 hormones. Now, if you remember, and I want you to write this down because this is an NREMT question, is what does the pancreas secrete? It secretes 2 hormones. One of them is insulin. Who knows the other one? All right. Fair to know. Gonna have to look it up. The beta islet cells of the pancreas is where the insulin comes from. Now you get some pancreatic juices that are digestive juices, but that's not endocrine. When you secrete a hormone into an open cavity, such as the gallbladder or the stomach, that's an exocrine gland. It's like your sweat glands. They're considered exocrine. They leave the body and go to another part of the body that's empty, such as the gallbladder, the skin as in outer space, as in the universe, and when it sits on your skin, and of course the pancreas when it's digesting things into the stomach. So, whoever's got the tones in the background, leave them on. I don't have a problem with it. If you have to leave, you have to leave. This is being recorded. You shouldn't have. You come back and get this later on. So you see the thyroid hormone stimulation from the hypothalamus. It goes to the pituitary gland, which then secretes TSH, and it goes to the thyroid, and it tells the thyroid start producing T3 and T4. Well, as you can tell, if you have a diseased thyroid and it's not responding, then that little T3 and T4 you see on the left-hand side of your slide there can't get synthesized, it can't get made. You'll see the word synthesize, big deal. It means it's not being manufactured, it's not being made, it's not being put together. And so subsequently, without the T3 or T4, which is essential for life, your patient will start showing some symptoms. All right. So let's get into two cases real quick here. One is going to be a hyperthyroid, the other one's going to be hypothyroid. If you're hyperthyroid, you're supercharged. So think about being supercharged. You got a tachycardia. You got a patient who's diaphoretic. This is why you guys go through the sample history. You're going to have to look for the meds. What are we on? Well, I'm a beta blocker. Why? Because I have atrial fib. Okay. What else do you take? I take this and this. Okay. Do you take any thyroid medication? No, my thyroid's fine. Fine. You're probably dealing with a cardiac dysrhythmia, rapid response atrial fib, and you shoot them with your favorite drug, either adenosine, a beta blocker, cardizem, something along those lines, ABC. Adenosine, beta blocker, calcium channel blocker. Or you can use amiodarone. More and more services are carrying amiodarone. But in this particular case, you ask the patient, excuse me, you ask the patient, are you on any thyroid medication? Yes, I am. Have you been taking it every day? I have been. How long have you been feeling this way? Oh, about 2-3 days or so. My doctor just recently increased the dose of my thyroid medication. When they're tachycardic, running a fever, and they seem to be altered, you know that you got a problem, and it's probably related to the thyroid. So your protocols should include a beta blocker, which will slow these patients down, especially when they have a dangerous arrhythmia. But you treat this arrhythmia like you do any other arrhythmia. If your patient's got in this particular case, got a 140 heart rate, but let's say it's 180, the pulse and the blood pressure is 60 pal, they're going to get a cardioversion. You can get them cardioverted, but then you're sitting there going, well, they're hypotensive, I can't give a beta blocker. That's going to be the dead giveaway for this particular patient, in that a hyperthyroid patient that you see in this case is going to have three things that you can pick out. Number one, they're on thyroid medication. Number two, they have a high heart rate with a high blood pressure. And subsequently, they could be running a fever as well. It can drive the glucose sky high. You saw on the previous slide, go back to it for a second. I can't go back. Okay. So you see on the previous slide, glucocorticoids, corticosteroids are produced, and they provide part of the feedback. So your steroids are going to go by as well. So a good competent protocol is going to include beta blockers, and if the patient's around a fever, you need to give these patients steroids, either hydrocortisone or Decadron, whatever you're carrying. They're going to at least stabilize this person for a while. But the mainstay therapy for a person on an NREMT question that is on thyroid medication, that is tachycardic and hypertensive, is a beta blocker, period. It may or may not be in your protocols, but when you see something like this and you're wondering what you need to do, in this particular case, maybe better off just picking up the phone and giving us a call so that we can give you a direct order either for the beta blocker, from steroids, or just to go ahead and say, all right, you're 5 or 6 minutes away. They can handle it for another 5 or 6 minutes. If you're longer than 15 or 20 minutes out, I'd order the beta blocker and probably a steroid with it. So be alert for the hyperthyroid guy. He's going to be on your exam. Okay. we're going to tell you something like thyroid disorder for years. Now, how do you tell the difference between a thyroid patient and a psych patient? In a lot of cases, you cannot. Before we admit a patient to a psychiatric unit, we get a series of blood tests on them to medically clear them for psychiatric hospitalization. One of them is the thyroid stimulating hormone, which we could measure in the blood directly. If the thyroid stimulating hormone is suppressed, if it's really low, it means that I've got a free T3 and a free T4, which are the two different types of thyroid hormones. There's too much of it, and I can measure those. There's too much of it in the system. And so it can drive a patient psychotic. This is another reason why patients are brought to the emergency room and EMS is called to transport intoxicated patients, altered mental status patients, febrile patients, psychiatric patients. Why? Because all may not be as it seems. You get the alcohol patient who's staggering all over the place, but he's in his 60s or 70s, and all of a sudden you've got yourself either a stroke or you got yourself a thyroid crisis going on. Something weird's going on with some of these patients. I'll admit 99.999% of the people coming intoxicated are just that. They're intoxicated. 99% of the psychotic patients that come in are probably psychotic, and they give you a whole list of medications. Or the big clue is, are you allergic to anything? Yeah, I'm allergic to Haldol. Okay. Any reason why they gave you Haldol in the past? Yeah, well, you know, I was schizophrenic at one time, but I'm not now. Okay, that's a line of BS. Once a schizophrenic, you will carry that diagnosis forever. Same thing with bipolar disorder. So psychotic patients really need to be evaluated very carefully, because if they get tachycardia and you find out that they're on a thyroid medication, you could very well be dealing with a thyroid storm. Just too much of it out there. Now, I'm overplaying this with you guys right now because we're only going to be on here for a short period of time today. And I just have to hammer home, know your hyperthyroid situation, your thyroid storm. Okay. Anybody have any questions? I've got all your mics open, so just chime in.
Was the second hormone that the pancreas produces, was that insulin and glucagon?
That's correct. Very good. Very good. Now that's a great answer. Insulin and glucagon. Here's your NREMT question. The pancreas secretes which of the following? And it's going to give you 4 answers, but each answer is going to have 2 hormones listed. And it's going to give you the right answer, which is glucagon and insulin. But it's going to give you insulin and some other BS. It's going to give you glucagon and epinephrine. It's going to give you thyroid stimulating hormone and follicle stimulating hormone. I mean, it's really going to throw a lot of stuff out there. It's going to come down to 2 answers, though. It's going to be the one that has the insulin in it. So if the answer doesn't have insulin in it and it's asking for pancreatic secretion, cross it out. Or mentally in your head, obliterate the letter. If it's an ABC question. All right, any comments or criticisms on that? I just gave you a question to your next NREMT, your paramedic test. All right, let's press forward. Your exam, they're going to be hyperactive. They're going to be speaking fast. They're going to be jittery. They're going to be tremorous. They're going to be restless. You feel their neck, and they're not really tender. If they're tender, could give you a clue. If it's not tender, doesn't mean anything. But you always feel the neck in the area of the thyroid, which is right here, right at the cricothyroid cartilage. And if it feels enlarged, you probably got a thyroid situation going on. Nobody will ever fault you for giving a beta blocker to slow this patient down. A documented person who's on thyroid medication, they took too much or had a recent dosage increase, be thinking thyroid storm. But you'll get that on the National Registry. But again, the dead giveaway is the question will include a tachycardic, hypertensive, restless, tremorous patient who is on thyroid medication. All right. Any questions? Pressing forward. Low pressure 5Q5 times 3 is fine. If you got labetalol, great. If you carry Indorol, and back in the day when I was a paramedic in the 70s in Chicago, we carried all of that stuff. And we were allowed to go ahead and give it, but we can only give it with medical control. You had to pick up the phone and actually call the hospital for every call. Now you guys got protocols laid out where you don't have to call unless you got a big question. I think a thyroid patient, a thyroid storm, where you're about to administer a beta blocker, you should probably be in touch with one of us, that we can guide you through this whole thing. What can precipitate a thyroid storm? I see the list there. The mnemonic is vitamin. You don't have to know it for the test, but I'd like you to know it for that one patient a year that you're going to run into that's probably going to have a thyroid issue. Just know all these things can trigger it. Here's the problem. Everything on here that can trigger it is probably a primary problem, and you've been called because they've got a cerebrovascular accident, i.e. stroke. They flip the PE, you're going to be treating them with that, with probably intubation. If they go into PEA, you're going to do all that. Myocardial infarction, geez, you're going to be treating the heart. So it's hard to really pick out the thyroid here, which is why the question that I outlined for you and gave you the answer to is the only way you're going to see thyroid pathology, a thyroid storm, presented on the National Registry. Now, you get a fever, altered mental status, and hyperthyroidism in an older patient. Gee, that's never happened. That's all you pick up in the nursing homes. And if you're fortunate to be in an area where you can help out these older folks as they are living, if you call it that, in a nursing home, you're going to be picking up febrile, altered mental status, older patients for a long time. Subsequently, it's important to grab the MAR, the Medication Administration Record. You need a copy of that to bring to the hospital so that we can tell, we can see what medications are on so we can start giving medications appropriate to that. I get levels, blood levels. When I see one high, knock it down. When I see one low, I build it back up. It's not rocket surgery. But what is dangerous is if you miss a thyroid storm, because about 30% of them are fatal. And if you miss it, you get them into the ER and go into full arrest, we got some big problems. Okay. The other thing you don't want to do is you got a septic patient and they are hyperthyroid. They've been treated, God bless you, when they're being treated for hyperthyroidism. They're going to look like a septic patient. So you're going to really react to the blood pressure more than anything else. If the blood pressure is high, they've either stroked, or they're in a thyroid storm, or they're in something else. It's going to, like I said, it's going to be very hard to pick out while you're on the scene. And diarrhea, nausea, abdominal pain, not a big help. Liver dysfunction, you have no way of figuring that out on the scene with lab tests. But if you pick up a patient who's got liver cirrhosis, big drinker their whole life, or they're one of those unfortunate people who picked up the other type of cirrhosis where they never had a drink in their life, it's still liver dysfunction. They tell you, well, he's on a liver transplant list and he's on thyroid medication, blah, blah, blah. There's a good bet that this is a hyperthyroid situation. Confused, tremor, and agitated, anxiety, restlessness, and delirium. Yeah, we've never seen that in another person. You know, of course, you're going to see all of that. It's going to mimic and it's going to look like everything else. You're probably sitting there going, how the hell am I supposed to tell if they're on a thyroid medication? Or I'm sorry, if they're on a thyroid storm. And the answer is you probably won't know. The history's pretty clear that they're on medication that just had a recent dosage adjustment. That's the question you're going to see on the National Registry. One question on hyperthyroidism. Okay, so let me just jump ahead a little bit. This is the hypothyroid situation, but this is a hypothyroid situation that you're going to see on your National Registry exam, which involves an athlete. So commit this one to memory as well. This is going to be a young person, 17, 18, 19, 18 to 25, somewhere in there, 16 to 25. This is going to be their first presentation for a thyroid issues around that time. They've been playing football or baseball or basketball the whole day before, replenished their electrolytes, at least they thought so, drank a lot of water, went to bed. The next morning they wake up and you get a call because this 21-year-old's laying in bed and he can't move his legs or he can't move his arms. And he's scared to death because he feels like he's paralyzed. And this is going to be a very classic case of a person who's got a low potassium, hypokalemic hypothyroidism. It's called a periodic paralysis. Now, it's in cycle 5. When you take your exam and you click on for the next question as you get it right, some of you guys are getting a lot of it right, and girls. When you get a lot of questions right, the questions are going to get a little bit more difficult. Right, that's adaptive learning. That's just what we do. And subsequently, you're going to run into about the third or fourth question. You're going to run into a person who's young, played sports the day before, replenished his water, but now can't move his arms or legs the next day. What do you think about? You think about this hypothyroid situation. So what are they going to get? Well, this is the history that you're going to get. Vital signs aren't a big help. That glucose should read 76, not 7.6. No wonder he can't move. And recently immigrated, so you're going to see kind of a mixed nationalities here, if you will. But it can happen to anybody. Asians are particularly vulnerable to it. White males, particularly vulnerable. Black males, somewhat vulnerable. And we're not sure why the genetics and why the race plays into this, to be honest with you. It's just curious that, we don't see it much in the African-American population. We see a lot of it in the Asian population, some of it in the white population. Just be alert. They're going to give you the scenario for the hypothyroidism, for the periodic hypokalemic paralysis. The scenario is going to be exactly what I just put in front of you. It's going to be a 18 to 25-year-old male, just played sports the day before, drank water, and woke up the next morning not moving his arms or legs. So you're going to be looking for hypothyroidism. Okay, so you're going to do an exam, and he's not moving. He's not doing much, but he's scared. You're not going to do rectal tone, obviously, out there. So that is your periodic hypokalemic. You may see that question. The first question you saw, hyperthyroidism, you will see that question exactly as I outlined it. The second case, the periodic hypothyroid hypokalemic paralysis, you're going to see maybe. It may be on one of the cycles. By the way, 15 years ago, we did a little research on it when I was in Corpus Christi, and we wrote a paper on it. You may see a paper out there floating in the literature that's got my name on it. I was a senior author on it. And so my influence on the National Registry test writing committee, I've used this question and framed this question in such a way where we use it in a third or fourth level. As you click on things, you get it right, you get it right, you get it right. We put this question there to finally have you get one wrong, so it kicks you to the next category. It'll test you all the way up to, God knows what. You may or may not see this question. Okay, I mislabeled the case here. There should be case 3. I can't warm up. This case.
Can I ask a question about the last case, sir?
Yes, Liz.
So how would I differentiate between hypokalemia and hyponatremia?
You won't. Hyponatremic patients tend to seize. Hypokalemic patients tend to not move because they don't have any potassium to depolarize the muscles to make them move. But just like the myocardium, the potassium has to be there. Pumps in, depolarizes, gets pumped out, sodium replaces it, and they switch back and forth with every heartbeat. If you don't have enough potassium, you get a very slow heart rate and you get a low blood pressure. Hyponatremia, on the other hand, your patient is going to be altered, confused, the same way that they would be with the with any other febrile illnesses, maybe hyperthyroidism and a lot of tachycardia. But when you see the bradycardic hypotensive patient who is excited and is talking to you clearly, that would be a low potassium. For the hyponatremic patient, the low sodium patient, when they get below 120 on their serum, they're going to start being altered and they're going to start seizing. And subsequently in the field, I'm not sure that you can tell the difference because you remember something. Every disease has a spectrum. You have no idea where in the spectrum you all of a sudden take a snapshot and you've got this patient. You'll get 10 EMS calls on thyroid patients. You may catch them early with tachycardia and nothing else going on. And yet you might catch them later with tachycardia, altered mental status, fever from the hyperthyroidism, confusion, and restlessness and tremors. That can mimic hyponatremia as well. They get tremors and then they start seizing. Liz, what we're going to try and do as EMS medical directors is we're going to, over the next 5 years, and I've trialing this on one of my EMS systems now, we're going to give you guys eye stats. You take a glucometer right now, you do a finger stick. You take that stick and you stick it in a glucometer, and what do you got? A blood sugar. You look right at it, it goes, oh, look at that, 120. You're going to do the same thing. You're going to poke the finger, you're going to stick it in a machine that's handheld, and you're going to look at it, and here comes sodium, potassium, chloride, glucose, BUN, creatinine, maybe or maybe not a TSH, a thyroid. Depends on the quality of the ISAT, depends on the resources within your system. I mean, if you belong to a system or a firehouse where they're passing the can around just to keep coffee in the house, you know, you're probably not going to see that. But if we can get the iStats on the rigs at a cost that's very, very low for the patient, maybe $2 or $3 per test, we're going to win out. Medicare is already reimbursing us for the iStats. At this point, we're going to teach you then about electrolytes. So to answer your question, Liz, unless you got that handheld iStat sitting right in front of you, you know what? Most of the time, you're just not going to be able to tell the difference between hyponatremia and hypokalemia and hypothyroidism. They all look alike.
We actually do use iStats in our current system. I'm with the National Park Service, and Grand Canyon has so many issues with hyponatremia that we actually have moved to iStats in the backcountry in hypertonic saline to try to address that.
Perfect.
So
I love it.
Nationwide.
If you're carrying 3%, now remember a 0.9 is 0.9, that's normal saline. 3% is hypertonic saline, 3%. That's incredible. And subsequently, that's a good advanced system with an outstanding EMS medical director. And if he has taught you that a seizing patient that has an iStat which shows a sodium of 115, you're gonna be a star. You're gonna save a lot of lives, because this is no joke when you get into hyponatremia. Guess who gets hyponatremia more than anybody else? There's only two types of patients: cancer patients and marathon runners. Why? Because the day or the 2 days or 3 days before the race, what do? They load up with water, and they load up with too much water. They don't use an electrolyte balance, they use water. They should be using Powerade, Gatorade, or one of the electrolyte solutions. You know, there's 1,500 National Football League players out there, and guess what they drink on the sidelines? Gatorade. Why? Well, probably because Gatorade throws $20 million at them a year to be sponsored. But at the same time, it's the perfect balanced oral electrolyte solution. If you don't have Pedialyte for your kids, give the Gatorade. It's got electrolytes. So Liz, congratulations on belonging to a great system. I appreciate the hypertonic comment. I really do. I'm just trying to hydrate here myself. All right. So now here's the other scenario, and this is the way you're going to see it. If these statements that you see come up on the National Registry look suspiciously similar to the ones that I got in the slides here, you'll know where they come from. So in this particular case now, which should read case 3, we're going to talk about the hypothyroid situation. Generally, this is an older patient. They're going to be in their 70s. When they hit 75, they're considered golden age, you know, old age. But up to 75, up to 74, some patients at age 60, they're already sedentary in bed, lost half their limbs and such. But in this particular case, you're going to get about a 70-year-old patient. The non-English speaking female is a detractor. Don't get detracted by that. We put that in there as a red herring. What do you care? Don't you care if they don't speak English or not? And does it mean anything that they're Spanish and yet people who are born and raised here in America won't get this? The answer is no, they won't. So in this particular case, 70-year-old female brought to EMS, to me, with decreased level of consciousness and function over the past 2 days. You get on the scene, you notice that the patient's kind of malaise, fatigue, weakness, a little bit confused and stuff. You hook them up on the monitor, and guess what the vital signs are? Oh, probably 45 to 55, heart or respiratory rate 6 to 10, glucose 50 to 60, and they're a little bit on the hypothermic side. You put the thermometer on them, it's 35. Past medical history for hypertension, rheumatoid arthritis, shingles, bilateral hip replacement, and their only meds right now is a water pill. So what happened to this patient? They have a first-time presentation. If you ask about meds and they're not on any thyroid medication, but yet they present in this way, you could very well have a hypothyroid situation. Now, back to Liz's question. Does a hyponatremic patient look this way? Generally, they're agitated. Although you can get the patient with malaise and fatigue if they get their sodium down below 115, but at that point, they're seizing. In this particular case, patient's just kind of lethargic, malaise, fatigue. They look like one of your mannequins in your prep classes. They're just there. You can pick them up, the arms fall back, the head falls back, the head falls forward, falls side to side. You put them on the stretcher, you get them in, they feel like a rag doll. Watch for the hypothyroid patient here. Now, is there anything you can do about it on scene? The answer is probably not. They need IV fluids, and they need a 0.9 normal saline because, like Liz had pointed out, they could be hypothyroid, hyponatremic, or hypokalemic. So now I raise my hand to the instructor and I say, well, then why aren't we giving lactated ringers? Because it's got electrical lights in it, electrolytes. You can tell I've been in the inner city in Chicago for too long. But they get electrolyte imbalances. And lactated ringers would be a good IV solution to start on these patients as well. Nobody will fault you for giving an electrolyte solution instead of a 0.9. If your system doesn't carry LR, fine. It's just the way that it is. But if you've got lactated, that might not be a bad start here. So low salt. There's Liz's comment again. Over the past few months for low salt confusion lethargy. They have a puffy face. They can't warm up. They're cold. They've got a temperature at 35. Now you're looking at the patient. They're profoundly bradycardic. They're hypotensive. They're hypothermic, decreasing respiratory rate. You throw a capnography at them, and you better throw away capnography on your patients when they've got decreasing levels of consciousness. And you're going to see the CO2 in the 50s or 60s. No history of COPD, no asthma, no congestive heart failure. They just present like this. So you think, sepsis, right? I'll start a lactated, I'll start a 0.9, give them a liter, give them 2 liters before I get into the hospital. I'll give them some steroids. Nobody's going to fault you for giving steroids. If the patient's hyperthyroid, it's going to help. If the patient's hypothyroid, it's going to help. If the patient is not hypothyroid and they're low sodium and low potassium, it's not going to hurt. And nobody's going to fault you for it. So if you can't get in contact with one of us and you really smell a sepsis or a low potassium for a low thyroid, you can go ahead and give your corticosteroids, prefer Decadron, because we're going to have to do some testing when they get in there. And Salucortep, Salumedrol, some of the other steroids, except Decadron, will screw up the test. So we prefer you give Decadron. It's safe, it's immediate, it's very potent mineralocorticoid, and most importantly, or glucocorticoid, and most importantly, it's not going to hurt anybody. Now remember, you're training at the paramedic level. You're not EMTs anymore. And so we get into some of the zebras that we're looking at because you actually run into this. Myasthenia gravis, I saw in the emergency room 2 weeks ago when Sherman paramedics brought in a patient, and it turns out that he had myasthenia gravis. Gave him the 10th line, he got a whole lot better. Masticon is the medication that you can give IV as well. These are all weird stuff that I'm talking to you about, but you're at the paramedic level now, and you have a need to know. Quite frankly, you have a right to know, and quite frankly, the people that you're treating expect you to know, or at least ask the proper questions. You may not get to the diagnosis in the field. Hell, we might not even get to it in the hospital for a day or two. But treat the emergency. This patient I'm giving to you right now, GCS of 8, bradycardic, hypotensive, hypothermic, decreased respiratory rate, increased CO2. Memorize those 4 circles, and you've got yourself the hypothyroid patient that's slipping into what they call Myxedema Coma. The greatest threat to these patients that are getting lethargic, malaise, and fatigue and really slipping down, and now they've got changes in their vital signs with a low blood pressure, low pulse, mental status that's bordering on 8. Remember, if it ain't 8, you're going to intubate. And you're going to be really, really concerned about these patients. If they're septic, you give them steroids, you save them. If they're septic, you give them fluids, you give them Levophed, you save them. And it's the same thing here with Myxedema Coma. Give the steroids, give a vasopressor if they won't come up with the liter or 2 bolus, and you may be dealing with a hypothyroid patient. But that's all you can do in the field. Don't forget the steroid. Most importantly, get the fluids on board, give the fluid boluses. Now, if you belong to a fire department or an EMS agency that is 5 to 10 minutes away from the hospital, hell, you're probably not even going to get 1 liter in before you arrive at the hospital. If that's the case, perfect. We can live with it. Just recognize the fact that, hey, what medications are you on? And then find out what medications are you supposed to be on that you haven't been taking. And you're going to catch some of these patients, like the son in this case, is going to have a history for you that she hasn't been taking medications. Or she ran out. You walk into a house, you see that it's okay, a little bit messy, the temperature is way down cold, she's wrapped up in a bathrobe, it's dead winter in a cold area, and you're going to see that it's an elderly patient that's trying to save money because she's on a fixed income. She's got the heat turned way down, she's in a sweater, bathrobe, long underwear, maybe even running sweatpants to stay warm, and they're taking their medication every other day so that they don't have to run to the pharmacy and spend whatever fixed income they have. They have to be very careful. And I just, bumped to the next slide here. You have to be very, very careful about when you walk into your environment, you're looking for safety issues. You're looking for threats that are going to be coming at you. Is the scene safe? When I give you guys your final exam, you should be looking at some of the old ones that we have recorded that are online, because I can assure you it doesn't deviate much. You're going to be getting a medical scenario, you're going to get a trauma scenario, and both of them you're going to be asked, you arrive on the scene, start your scenario. First words out of your mouth. I get my VSI on. Is the scene safe? What do I see? Single victim, okay house, a little cool, a little cold, dead of winter. This is going to be your clue. What medications are you on? I'm supposed to be on these medications. They're taking them every other day or every third day so they don't have to spend their money because they don't have any money. So be alert for the fact that your patient may be underdosing themselves, non-compliant, not even taking medication. And you're going to find these hypothyroid patients more in that scenario than you're going to find anyplace else. So glucagon or dexamethasone. If you want to be safe, glucagon. You know what? I forget which one of you fellows told me the correct answer, glucagon insulin. Who was that?
It was me that said that. Tyler.
Okay, Tyler. Nicely done. All right, Tyler. So you got this one buried in your mind. Okay, these diagnoses are clinical. Search for precipitating causes, search for that environment that I was talking about. Make sure you're asking your sample history. Make sure you're asking about meds. And the meds are, what are you taking? Number 2, what are you supposed to be taking? Number 3, have you had any dosage adjustments lately? Those are going to be your big clues when it comes to endocrine emergencies. I'm focused on this. It should be a matter of habit, but I'm focused on this because that's the way it's going to appear on your national registry. Does anybody have any questions about what we talked about?
No, sir.
Click in and talk to me.
No, sir.
All right. That's Jerome.
Yes, sir.
I don't have
Nope.
any, I believe.
Stetson, you got any questions?
No, sir.
Liz?
No, I think you addressed mine.
Tyler?
No, sir.
Dalton, you still with me?
Yeah, no questions.
All right, very good. All right, like I said, you're probably only going to see the hypothyroid and hyperthyroid. You're not going to see adrenal crisis. You won't see myasthenia gravis. The hypothyroid patient is going to be a very obvious one. It's not going to be the person who's just kind of lethargic like that kid I was telling you about. You may or may not see that question, although I did include it in the cycle 5. But the third case we talked about, the first case and the third case, you're going to see that scenario. Commit it to memory. All right. Well, I enjoyed my time with you guys today. We're 40 minutes into this, and I think that's about as much as we want to talk about for a subject that's not highly tested.
Thank you, Dr. Frame.
All right. You guys take care, and thank you for joining me tonight.
Thank you.
Thank you.
Hey, Dr. Frame, I have a question for you if you're still on there. Which Collin County Fire Departments are you the medical director for? I can't hear you right now because I believe you're still muted, but I was just wondering. I still can't hear you, sir. It looks like you're still muted.
Unmute me. Okay. Tyler, you still there?
Yes, sir, I am.
All right. Question again?
Which Collin County Fire Departments are you the medical director for?
Westminster, Bells, South Maid, and shortly here, one of the other departments up north, Sherman.
Oh, really? Okay. I've never heard of those. I'm looking to work in the Dallas area here in the next 6 months or so, maybe in the city of Dallas or somewhere else in Collin County or something. So I was just wondering. Thank you, though.
Well, Tyler, if you ever see me in the emergency room at Wilson and Jones, please make it a point to come in and talk to me.
I will. Absolutely. Thank you.
All right, Tyler, you take care of yourself. Hope you can rotate at least one ER shift with me. You'll work your ass off and you'll leave there 10 times the paramedic you walked in as.
All right.
I'll work your
Thank
butt.
you, sir.
Yeah, okay.
Have a good night.
You too. Bye-bye.